Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. In this lecture, we will be discussing mucolipidoses and mainly inclusion cell disease, also called as eye cell disease. Apart from that, I will be explaining you glycophosphatidylate inositol linkase, the disease that is associated with a defect in glycophosphatidylate inositol linkase called as paroxysmal nocturnal hemoglobinuria. Let's get into the details. The degradation of glycoproteins and how mucolipidosis happens. Note that specific lysosomal glycosidases, usually these glycosidases are exoglycosidases, they are involved in the degradation of glycoproteins in the lysosomes. Now, oligosaccharide chain that is attached to the glycoproteins is degraded sequentially starting from the non-reducing end, and that needs a specific lysosomal enzymes which will remove these monosaccharide units attached to the oligosaccharide chain, carbohydrate chain attached to a protein molecule. So, specific enzymes which are taking this out, these carbohydrates out in the degradation process can be deficient. And since this degradation is going on in the lysosomes, so all the enzymes are acid dehydrolases, lysosomal acid dehydrolases. So, a defect or deficiency in one or the other lysosomal acid dehydrolases will give rise to accumulation of specific type of glycoproteins in the lysosome, and that may give rise to disorder. So, the mucolipidoses show accumulation of partially degraded glycoproteins, glycolipids and oligosaccharides in the lysosomal cells. All of them are placed under mucolipidoses category. So, mucolipidoses are of four types. Mucolipidoses type 1 referred as sialidosis. As the name says, sialidosis includes the accumulation of sialic acid containing glycoproteins. And the mucolipidosis type 2 is referred as eye cell disease, also called as inclusion cell disease. Eye there is inclusion, that's why it is called as eye cell disease or inclusion cell disease. Mucolipidosis type 3 is pseudo-Hurler polydystrophy, and then we have mucolipidosis type 4, which is not a named disorder. Coming to mucolipidosis type 1. Mucolipidosis type 1, which is referred as sialidosis, it is an autosomal recessive condition where there is a mutation in NEU1 gene which is coding for neuraminidase. The enzyme neuraminidase is also called as sialidase, which is responsible for removal of sialic acid. Sialic acid is N-acetyl neuraminic acid. That's why the other name of sialidase enzyme is neuraminidase. So, sialidosis type 1 and sialidosis type 2 can be found, and out of these two, sialidosis type 2 is more severe than sialidosis type 1. Now, let's look at sialidosis type 1 first. The signs and symptoms in sialidosis type 1 appears in the second decade of life, and patients will have involuntary muscle contractions referred as myoclonus. Patient will show cherry red macula upon retinoscopy, and neurological deficits can be seen, and usually the intelligence is not affected in sialidosis type 1. Whereas in sialidosis type 2, the signs and symptoms appear in the infancy or later during childhood. That means age of onset of sialidosis type 2 is much earlier than type 1. Cherry red macula is seen, coarse facial features like gum hyperplasia, protrusion of the tongue, depressed nasal bridge, frontal bossing, averted ears, short neck. This type of facial features can be seen along with the clouding of cornea. Note that. And the clouding of cornea can also be seen we have seen that in mucopolysaccharidoses lecture. And the patients with sialidosis type 2 will also show skeletal malformations and mild cognitive impairment. They can be impaired color vision, night blindness, nystagmus, seizures, hyperreflexia, myoclonus, and infants with congenital form may also develop hydrops vitalis. Overall, 𝐒𝐮𝐬𝐈dosis type 2, it is much severe than 𝐒𝐮𝐈dosis type 1. So remember, the enzyme that is deficient in this particular disease is neuraminidase or 𝐶Lidase, and the gene that is mutated is NEU1 gene. Coming to our next disorder is mucolipidoses type 2, which is also called as inclusion cell disease or eye cell disease. Now, the eye cell disease is because of a defect or deficiency in an enzyme called glucnac phosphotransferase or N-acetyl glucosamine phosphotransferase. And this N-acetyl glucosamine phosphotransferase, location of this enzyme, either it is in endoplasmic reticulum or in the cis-Golgi. So this enzyme, that is N-acetyl glucosamine phosphotransferase, which we have seen in my earlier lecture, I have already explained to you, that is glucnac phosphotransferase. This is the enzyme which will transfer phosphate to the mannose residue present over a N-linked glycoprotein, which are basically enzymes which are destined to go to lysosome. So the chemical marker for lysosome is mannose 6-phosphate. So the addition of the phosphate to the 6th carbon of mannose over a protein which is synthesized over rough endoplasmic reticulum, entering into the lumen of endoplasmic reticulum and targeted to the lysosome. So the targeting chemical marker is mannose 6-phosphate. So phosphorylated mannose is necessary on the protein to go to lysosome, and that is what is done by glucnac phosphotransferase. So if that enzyme is deficient, so the phosphorylation of mannose do not go on. That means enzymes don't reach lysosome. So otherwise, normally what happens, mannose 6-phosphate, which is there over a glycoprotein, so it will move to the trans-Golgi, and the trans-Golgi there is a mannose 6-phosphate receptor. It's going to bind to that, and transport vesicles will take it to lysosome. Receptors are recycled, enzyme gets into the lysosome. That's a normal process. So these are lysosomal acid hydrolases going to the lysosome, involved in degradation of proteins, lipids, nucleic acids and carbohydrates. All the things that are dumped into the lysosome for degradation will be taken care by acid hydrolases going in, which are present in the lysosome. And those acid hydrolases, which are glycoproteins, they need to be targeted there normally, and that targeting needs mannose 6-phosphate. So in eye cell disease, addition of that mannose 6-phosphate will be defective, because most commonly the mutation that is seen causing this disease is mutation in the gene coding for glucnac phosphotransferase. It can also be because of mutation in a gene coding for mannose 6-phosphate receptor, which is present over trans-Golgi, but that is less likely compared to the most common one, that is glucnac phosphotransferase enzyme being defective. Now let's get into the details of the disease. Eye cell disease, it is an autosomal recessive condition because of mutation in GNPTA gene, which is coding for UDP N-acetyl glucosamine phosphotransferase or glucnac phosphotransferase, which is located in the Golgi, like cis-Golgi. The condition is very similar to Hurler syndrome, but with the absence of excess mucopolysacchariduria. That means the signs and symptoms that we have studied in Hurler syndrome in mucopolysaccharidoses. So in Hurler syndrome, there will be excess dermaton sulfate, heparan sulfate in the urine. That type of mucopolysacchariduria may not be seen here in eye cell disease, but the signs and symptoms with coarse facial features, corneal clouding, cardiomyopathy, kyphoscoliosis, protuberant abdomen, and then hearing loss, cognitive defect like mental retardation, all those signs that we have seen in Hurler syndrome will also be seen in eye cell disease. So, Hurler syndrome can be a differential diagnosis for 𝐼Cell disease. Remember that. But we have ways to differentiate Hurler and 𝐼Cell disease. We will go into the details as we move on. Now, 𝐼Cell disease appears to be more common in Japan than other countries. Remember that. And decreased mannose-6-phosphate attachment over protein which are destined for lysosome is the defect here, because glucanac phosphotransferase is defective. So because of this, what will happen? The proteins that are destined to go to lysosome, now they don't go there because mannose-6-phosphate is not there, that chemical marker is not there. Because of this, what will happen? There will be decreased intracellular levels of lysosomal enzymes. And instead of going to lysosome, these enzymes by default, they all will be exocytosed into the extracellular matrix, and eventually they will find their way into the bloodstream. So there will be elevation of lysosomal enzymes in the blood, which they don't have function there in the blood. They need to go to the lysosome normally, but since mannose-6-phosphate is not there, they are all diverted outside, and eventually their levels will be elevated in the blood and body fluids. And remember, these are acid hydrolases. That means they need acidic pH to work. Whereas in the blood, we don't have acidic pH. pH is 7.4. So that's why acid hydrolases in the extracellular matrix or in the bloodstream, they have no to nil activity or little activity. So what happens in the lysosome? The things will get built up because necessary enzymes are not there to degrade the material that is coming to the lysosome. So lysosome continue to accumulate all kinds of material, and because of lack of enzyme. So let's see what happens here. So abnormal accumulation of mucolipids and mucopolysaccharides within the lysosomes happens. Signs and symptoms may appear at birth. So it can be congenital, or it can appear between 6 months to 10 months of age. So relatively age of onset is early here, so making the disease severe. Now, mental retardation may be severe and slowly progressive. However, the motor development is more severely affected than mental development in 𝐼Cell disease. Although both is affected, both mental development and also motor development, but motor development is affected much more severely than mental development here, right? So signs and symptoms: coarse facial features like Hurler syndrome, corneal clouding like Hurler syndrome, defect in heart valves, cardiomegaly like Hurler syndrome, congestive heart failure, unusually thick and tight skin seen in certain areas of the body, kyphoscoliosis like Hurler syndrome, unusually short neck like Hurler syndrome, dislocation of the hip at the birth can be like congenital dislocation of the hip, stiff joints and contracture like Hurler syndrome, and fused fingers, one of the things that you see here in 𝐼Cell disease, like a split hand deformity or ectrodactyly, that's what is referred as, which is seen in 𝐼Cell disease. And severely delay in the development of gross and fine motor skills can be seen. Hearing loss like Hurler syndrome, and hypotonia, degree of mental retardation can vary and can be severe because it is a progressive. Growth delay, short stature, severe hepatomegaly, umbilical hernia, inguinal hernia, all these are like Hurler syndrome. So majority of the signs and symptoms that you see here in 𝐼Cell disease will be similar to what we have seen in Hurler syndrome also. Now the death usually occurs by 5 to 8 years of age, usually because of cardiorespiratory complications, and that is also similar to Hurler syndrome. Coming to diagnosis, amniocentesis or chorionic villus sampling can be done, and lysosomal enzyme assays can be done in white blood cells or cultured fibroblasts. And typically, lysosomal enzymes are elevated in the blood and serum and decreased in the cultured fibroblast. That's the finding which will differentiate 𝐼Cell disease with Hurler syndrome, because in Hurler syndrome only a specific enzyme is deficient, that is α-L-iodronidase. This is a acid hydrolase. Like lysosomal α-L-iodronidase enzyme is the specific enzyme that is deficient in Hurler syndrome, whereas in 𝐼CEL disease, all lysosomal enzymes will be deficient or absent. So, treatment for 𝐼CEL disease is symptomatic and supportive, and benefit of bone marrow transplantation is limited here. And also going over a little bit into the diagnosis, like staining the material. The tissue staining will show accumulation of all kinds of material like carbohydrate accumulated, lipid accumulated, proteins accumulated, nucleic acid accumulated. So, the staining material here will show positive for PAS, so PAS positive material, that is periodic acid skiff material for carbohydrate, and also Sudan black B positive material, and can stain with ninhydrin for protein, ninhydrin positive material. So, all kinds of material being accumulated in the lysosome, which will differentiate with Hurler syndrome. In Hurler syndrome, it is only PAS positive material, not Sudan black B material, which is for lipid. So, now coming to the flow chart here. So, the figure that is given, it shows the coarse facial features and mutation in the gene coding for glucanac phosphotransferase, and mutant glucanac phosphotransferase giving rise to lack of normal transfer of lysosomal enzymes to go into the lysosome, so the targeting is not there. So that's why lysosomes are going out into the extracellular matrix, and eventually their levels are elevated in the bloodstream and leads to accumulation of all kinds of material in the lysosome, giving rise to inclusion bodies. These inclusion bodies are carbohydrates, proteins, lipids, nucleic acids, everything being accumulated, and lysosomes become big. So, that's what is inclusion cell disease. Coming to our next disorder is pseudo-Hurler polydystrophy, which is referred as mucolipidoses type 3. It is because of autosomal recessive mutation in GNPTAB gene, leading to UDP-N-acetyl-glucosamine 1-phosphotransferase enzyme deficiency. So, it is less severe form of 𝐼CEL disease. The phenotype is similar to Hurler syndrome but without mucopolysacchariduria. Age of onset is 2 to 4 years. Signs and symptoms, it is almost similar to what we have seen in 𝐼CEL disease, like including coarse facial features, clouding of cornea, stiffness of the hand and shoulder, carpal tunnel syndrome. So many signs and symptoms that we have seen in 𝐼CEL disease can also be seen here in Hurler syndrome. And some cases of pseudo-Hurler polydystrophy will show aortic insufficiency. Now coming to mucolipidoses type 4, is also referred as a Burman syndrome. So it is an autosomal recessive mutation in MCOLN1 gene, which results in deficiency of transport channel receptor protein, that is mucolipin 1. That's what is MCOLN1. That's the name of the gene, coding for mucolipin 1. So the exact function of this protein is still not known. Disease is characterized by intellectual disability, severe psychomotor retardation, hypotonia, clouding of cornea, and retinal degeneration. Coming to α-mannosidoses and β-mannosidoses. Alpha-mannosidoses and beta-mannosidoses is because of deficiency of α-mannosidase enzyme, that's for alpha-mannosidosis, and beta-mannosidase enzyme for beta-mannosidosis. So in alpha-mannosidosis, virtually all patients have psychomotor retardation, coarse facial features, some degree of dysostosis multiplexa, recurrent infections because of deficiency of cell-mediated and humoral immunity. Patients will have hepatomegaly, lenticular or corneal opicities. Lenticular opacity means opacity of the lens leading to kind of cataract. Now, α-mannosidose type 1 is more severe form of mannosidosis, and patients will have severe dysostosis multiplexa and death occurs usually within 12 years of age. Now, the α-mannosidose type 2 is like patients will have they are normal during early development, followed by gradual appearance of mental retardation. Hearing loss is particularly prominent in type 2 α-mannosidoses. Coming to β-mannosidoses, manifest with varying degrees of neurological findings with mental retardation. So, hearing loss and speech impairment can be seen, hypotonia, epilepsy, peripheral neuropathy, angiokeratoma can be seen in this particular disease. Remember, angiokeratomas or angiokeratoma is one of the sign of Fabry disease that we have seen earlier. So, in mucopolysaccharidoses. Coming to role of glycoproteins in fertilization process. A sperm has to interact with oocyte and penetrate the thick outer membrane of oocyte, which is called as zona pellucida, for fertilization to happen. A glycoprotein called ZP3 and PH30 are important in binding and interaction of sperm with an oocyte, and it may be possible to inhibit this fertilization by developing drugs that interfere with normal functions of ZP3 and PH30, which would thus act as a contraceptive agents. So, this ZP3 and PH30 are the glycoproteins that can be targets for contraceptive agents in preventing fertilization process. Now, there is a role of glycoproteins in intercellular adhesion. Leukocytes and endothelial cells contain cell surface lectins called selectins, which participate in intercellular adhesion. And lectins are glycoproteins, and the oligosaccharide chains which are present over lectins, they play a key role in the interaction between leukocytes and endothelial cells in inflammatory and immunological phenomenon. Selectins, they will bind with sialylated and fucosylated oligosaccharides, and sulfated lipids may also bind with the ligands. So, cancer cells often have these selectin ligands on their surface, which may have a role in invasion and metastasis of cancer cells. So, since this lectins, the particular type of lectin is like selectin, is a glycoprotein. So, the role of this selectin in intercellular adhesion is one of the things that can be a target for prevention of cancer cells, like stopping the metastasis if this type of selectins can be targeted in the treatment. Coming to leukocyte adhesion deficiency 2. Mutation in Golgi located GDP fucose transporter is the one that causes leukocyte adhesion deficiency number 2. So, absence of fucosylated ligands for selectins leads to markedly decrease in neutrophil rolling over the endothelium, because you need selectins for that process to go on. So, subjects suffering from this particular disease where leukocyte adhesion deficiency is there because of absence of fucosylated ligands for selectins to bind or interact with the endothelial cells for neutrophils to roll over. So, subjects suffer from life-threatening recurrent bacterial infections and also psychomotor and mental retardation. And this condition appears to respond for oral fucose supplementation. Coming to congenital muscular dystrophies. This results from defect in the synthesis of glycoproteins, that is alpha-dystroglycan, which is a type of glycoprotein. This membrane protein of muscle cells interacts with laminin 2, which is referred as myosin in the basal lamina. We have seen that the arrangement of laminins in our previous lecture in the connective tissue lecture series. So, defective glycans on So, the defective glycans on alpha-dextroglycan may result in defective interaction of alpha-dextroglycan with laminin, thereby giving rise to congenital muscular dystrophies. Now there is a role of glycoproteins in viral, bacterial and parasitic infections also. Let's get into a little more details in this aspect. First is like influenza virus A. Influenza virus A, it has a hemagglutinin protein which binds to cell surface glycoprotein receptors containing N-acetyl neuraminic acid. So neuraminidase is released from influenza virus and it plays a key role in allowing release of newly synthesized progeny from infected cells. So developing a neuraminidase inhibitors like zanamivir, oseltamivir can rapidly decrease the spread of virus, and also these drugs are used to treat influenza infection. Influenza viruses are classified according to the type of hemagglutinin that is synthesized from them and also neuraminidase that is synthesized. So example H1 and N1. So that is hemagglutinin 1 and neuraminidase 1. Like this, there are at least 16 types of hemagglutinin and 9 types of neuraminidase. So based on that, we have different types of influenza viruses, and they are classified as per the numbers like H1, N1, H2, N3, something like that. So it is about hemagglutinin and neuraminidase. These are the proteins, glycoproteins, which are interacting with the cell surface receptors. Then we have human immunodeficiency virus type 1, that is HIV type 1. It causes AIDS, and this virus attaches cells via one of its surface glycoprotein called GP120, and it uses another surface glycoprotein GP41 to fuse with the host cell membrane. So antibodies to GP120 develop during infection by HIV-1 virus. Now let's move on to see information on glycophosphatidylcholine inositol anchored proteins. So the structure that you are seeing here is, it is a GPI anchor. So as you see, this is the membrane here, plasma membrane. I am putting arrow just to show where is the membrane. Read at the below, like that's a plasma membrane. And fatty acid is attached to the plasma membrane, and there is a phosphatidyl inositol phospholipase C enzyme which can remove that. And after that, the second molecule that is attached is inositol, which is phosphorylated. That is what is phosphatidyl inositol. And then to that inositol, there is an attachment of glucosamine. So these enzymes, so in order to build this molecule, that is GPI, glycophosphatidyl inositol structure, this entire thing is glycophosphatidyl inositol structure. Each one of them need to be brought by a specific enzymes. So we have a fatty acid to that inositol which is phosphorylated, and then we need to add glucosamine. There is an enzyme to do that. It brings glucosamine and add it there. And then there is a mannose which is phosphorylated with ethanolamine, then mannose, and that mannose is phosphorylated with ethanolamine, and that is what is GPI. This entire structure is glycophosphatidyl inositol, and this structure which is attached to the plasma membrane, it gives as an anchor for certain proteins that can be attached. So the protein, like it is shown here, it is attached or interacting with ethanolamine, like amino acid glycine interacting with ethanolamine, and that's how the protein is attached to GPI, and GPI is attached to plasma membrane. So any proteins that are using GPI as an anchor to attach with the plasma membrane referred as glycophosphatidyl inositol anchored proteins. So examples for glycophosphatidyl inositol anchored proteins, and then we have alkaline phosphatase present in the intestine and placental membrane. Then we have decay accelerating factor present over red blood cell membrane, 5' nucleotidase present over T cells and other cells, and Thi1 antigen present over brain and T lymphocytes, and also we have variable surface glycoproteins found over trypanosoma brucei and all that. So these are some examples of proteins which will use GPI anchors to be attached over the cell membrane. So pay special attention to decay accelerating factor present over cell membrane, and also decay accelerating factor is also referred as CD55. And there are a couple of other proteins which are not mentioned here in the table, which also uses GPI anchors to be present over red blood cell membrane, and that is CD59 and also certain complement factors, which I am going to explain to you later. Now, the GPI linkage is the commonest way in which various proteins are anchored to cell membranes, as I have explained with some examples in the table. Now, note that GPI anchor is pre-formed in the endoplasmic reticulum. That means that entire structure which I have explained, which has inositol, phosphorylated inositol, then we have glucosamine, and then we have mannose, ethanollamine added. All this structure, GPI anchoring structure, it is pre-formed in the endoplasmic reticulum, and protein, as the protein is coming in, so it will be attached, and the inositol is added with the additional fatty acid and attached to a plasma membrane. Now, the functions of GPI linkage is proteins or enzymes using GPI anchor to attach with the plasma membrane will have greatly enhanced mobility. Some GPI anchors may connect with signal transduction pathways, and GPI anchors can target proteins to apical or basolateral domains of the plasma membranes of polarized epithelial cells. So, these are some of the functions of glycophosphatidylcholine inositol linkase. Now, let's get into one of the important disease that is related with defect in GPI anchoring is paroxysmal nocturnal hemoglobinuria. Pay special attention to this particular disorder. It's a very, very important disease. Now, in this disease, there will be mutations in X chromosome located PGA gene in bone marrow hematopoietic cells, coding for an enzyme that links glucosamine to phosphatidyl inositol in building GPI anchor. Because I told you, I have shown you in the previous slide that GPI anchor has got fatty acid attached to the membrane, and let me take you back to that slide. Here it is. As you see, there is a fatty acid attached to the plasma membrane, inositol which is phosphorylated, and then we have glucosamine. So that means each and everything here need to be added sequentially, done by a special enzymes which are bringing it, right? So, in paroxysmal nocturnal hemoglobinuria, what happens is, so the enzyme that is bringing glucosamine to be attached to this inositol will be defective. That's what happens in PNH. So, the PGA gene, that is phosphatidyl inositol glycan A gene, is the one that will code for an enzyme that will bring glucosamine, LCNH, glucosamine, to be attached to inositol. And that if that enzyme is defective, because PGA gene is defective, which is located on X chromosome, so that will lead to defective GPI anchor. So GPI anchor is defective because that glucosamine is not added, and that is the pathology that you see in paroxysmal nocturnal hemoglobinuria. So now I have explained you what is the defect in paroxysmal nocturnal hemoglobinuria because of mutation in PGA gene. It is the defective synthesis of glucosamine with phosphatidyl inositol linkase in making GPI anchors. So, cells harboring PGA mutation are deficient in GPI anchored proteins. And certain GPI anchored proteins, they are involved in protection of red blood cells from complement mediated destruction, and those are, you must remember them, is DAF, that is decay accelerating factor, which is also sometimes referred as CD55, that is colony detecting protein 55, and then CD59, which uses GPI anchors to protect red blood cells from complement mediated destruction, and C8 binding protein, that is complement 8 binding protein. So, especially these GPI anchored proteins which are present over the red blood cells. In fact, these GPI anchored proteins will be present over all hematopoietic cells like white blood cells, platelets and all of them. So DAF, CD59 and C8 binding proteins, what they will do is, they are all going to interact with C3b and C4b complements, and C3b and C4b complements, they are not allowed to be activated. Whenever red blood cells have DAF, CD59 and C8 binding protein over the cell membrane, so they are going to prevent activation of C3b and C4b. Thereby, they decrease a classic and alternate complement activation pathway and do not allow red blood cells to be lysed. That means they are going to protect our red blood cells from complement mediated lysis. It's like having DAF, CD59 and C8 binding proteins will give information to the complement system that these are our own cells and not to destroy them. It's like a passport for a citizen to enter into the country or something. Like not having DAF, CD59 or C8 binding protein over the cell membrane, the red cell having DAF, CD59 and C8 binding protein, they are going to prevent red blood cells from destruction from complement mediated action. Okay, so if there is no DAF, no CD59 and no C8 binding protein over the red blood cell because of GPI anchors being defective, so these proteins are not added, means attached over the cell membrane because of GPI anchor not there. So then that protection from complement mediated action over those red blood cells not there, because there is no protectors present over the cell membrane. So that means CB3, C4B, a classic and alternate pathways of complement system will be activated. They are going to lyse these red blood cells. So red blood cells will be lysed. So that means RBC lysis will happen. Hemoglobin will be released, leading to hemoglobinuria. And that's what happens in paroxysmal nocturnal hemoglobinuria. Not having DAF, CD59 and C8 binding protein expressed over the red blood cell membrane because of defect in GPI anchors will lead to the changes that will be going on in our body, especially hematopoietic cells. So what are the major issues that we see in paroxysmal nocturnal hemoglobinuria because of not having DAF, CD59 and C8 binding proteins over the red blood cell membrane and other hematopoietic cells and even including the other cells. So majority of paroxysmal nocturnal hemoglobinuria related issues are including destruction of red blood cells, that is patient will show severe hemolytic anemia. There can be blood clots like thrombosis because clotting mechanism is affected because the platelets express CD59, DAF and all that. So, and also the infection, risk of infection, which are all result from deficiency of GPI anchored proteins. Because the GPI anchored proteins will protect our cells and also will give a protective mechanism for our body in variety of ways. So not having these GPI anchored proteins over our cells will lead to abnormalities. It includes hemolytic anemia, thrombosis and risk of infection. So hemolytic anemia is due to lysis of RBC, especially during sleep because of drop in the blood pH, which will activate complement system. That's why RBC lysis is more significant during sleep and hemoglobin can come out and appear in the urine, leading to hemoglobinuria. So the morning sample of urine in a patient who is suffering from paroxysmal nocturnal hemoglobinuria may have more hemoglobin. So that is a nocturnal hemoglobinuria because red blood cells are destroyed during night because during night there will be slight drop in pH physiologically because of lowered respiratory rate and retention of the carbon dioxide. So this comes in attacks. So paroxysmal nocturnal means night time hemoglobinuria. Now that's about how hemolytic anemia happens. So the flow chart here, it shows the pathophysiology of paroxysmal nocturnal hemoglobinuria. Now the mutation in PGA gene of certain hematopoietic cells leads to defective synthesis of glucosamine phosphatidyl inositol linkase in GPI anchors. Decreased amounts in red blood cell membrane GPI anchored proteins with decay accelerating factor DAF CD59 being especially important here, and the complement system activated and leading to complement mediated red blood cell lysis and other consequences. Now the median age of diagnosis of PNH is 35 to 40 years of age, with occasional cases being diagnosed in early age also, like childhood or adolescence. Three underlying pathophysiological events can happen in paroxysmal nocturnal hemoglobinuria. One is acquired intracorpuscular complement mediated hemolytic anemia. Second is thrombosis in large vessels such as hepatic, abdominal or cerebral vessels. Third is deficiency in hematopoiesis may lead to pancytopenia, which might put patient at risk of aplastic anemia state. So disease is characterized by triad. Make sure you remember that. So the triad of hemolytic anemia, thrombosis and pancytopenia. So these three things must give a clue for the diagnosis of paroxysmal nocturnal hemoglobinuria. So hemolysis leading to hemolytic anemia, thrombosis and pancytopenia. So severe hemolysis leads to hemoglobin mediated nitric oxide scavenging, thereby depletion of circulating nitric oxide levels, and that leads to symptoms which includes abdominal pain, back pain, headache, esophageal spasms and erectile dysfunction. Patient feels fatigue in 80% of the cases. Patient will have dyspnea, difficulty in respiration. Hemoglobinuria is seen in 62% of patients. Abdominal pain and chest pain. This is how in decreasing order of frequently reported symptoms in paroxysmal nocturnal hemoglobinuria. Fatigue is the most common symptom of PNH. Now the classic symptom of bright red blood in the urine, that is hemoglobinuria, occurs in 50% or less of patients. Now hemoglobinuria during intravascular hemolysis is episodic. That means it can occur at any time of the day, but usually it occurs at night time. That's why it is called as paroxysmal nocturnal. So it is an episodic thing and usually occurs during night time because of slight drop in the pH. So hemoglobinuria occurring in the night time, referred here as nocturnal hemoglobinuria. So early morning urine sample is cola colored urine. Early morning urine is cola colored because of excess hemoglobin being appearing in the urine sample because of overnight hemolysis that was going on. As you see here, so the sample that is there in the center is the cola colored sample, like excess hemoglobin in the urine, and also you can see the changes in the intensity throughout the day. This is all hemoglobinuria samples, but the intensity of hemolysis can vary throughout the day. But usually the morning sample is the one that is highly intense, which is referred as cola colored urine. Now, thrombosis is the most common cause of death in persons with paroxysmal nocturnal hemoglobinuria. Make sure you remember that point, and it accounts for 50% of death because of this disease. Most frequent sites of thrombosis includes hepatic, pulmonary, cerebral and deep and superficial veins, as well as inferior vena cava. And attacks of hemoglobinuria may be brought on by infections, alcohol, exercise, stress and certain medications. So these are the things that can also lead to hemoglobinuria. Coming to diagnostic tests, that will demonstrate the presence of red blood cells that are exceptionally sensitive to hemolytic action of the complement. These tests include flow cytometry, acidified serum lysis and Ham's test, complement lysis sensitivity test, and sugar water or sucrose lysis test. So basically, in acidified serum lysis and Ham's test, what is done is a blood sample is taken in the test tube and the pH of the blood sample is slightly dropped, make it towards the acidic side, and see what happened to the red blood cells. So the number of red blood cells being lysed is measured, and that's what is the acidified serum lysis test or Ham's test. Sugar water test or sucrose lysis test is, so the sucrose, it's going, addition of sucrose into the sample, it is going to activate complements and thereby it lyses the red blood cell if a person has paroxysmal nocturnal hemoglobinuria. So most laboratories no longer perform Ham's test or sugar water test, but the flow cytometry is the test that can diagnose a suspected case of paroxysmal nocturnal hemoglobinuria. So what is done in flow cytometry is, flow cytometry detects CD59 and CD55, that is decay accelerating factor, over red blood cells. So absence or reduced expression of both CD59 and CD55 on the RBC is a diagnostic of paroxysmal nocturnal hemoglobinuria, indicating that GPI anchors are defective. So for routine analysis and for diagnosis of suspected paroxysmal nocturnal hemoglobinuria, standard flow cytometry test is sufficient. So make sure you remember that point. So the diagnosis of PNH, we use flow cytometry. Now, a modified flow cytometry, referred as fluorescently labeled inactive toxin aerolysin, which is called as FLIRE, is the most specific test for PNH, as the FLIRE binds the GPI anchored specifically. So this is the most specific test for paroxysmal nocturnal hemoglobinuria. Remember, the name of the test is a FLIRE test. So FLIRE is fluorescently labeled inactive toxin aerolysin. Now let's move on to see a treatment for paroxysmal nocturnal hemoglobinuria. The drug called eculizumab, which is also referred as Soliris. Now the eculizumab is an anti-complement monoclonal antibody targeting the C5 component of complement system. Eculizumab, it alleviates the hemolysis associated with paroxysmal nocturnal hemoglobinuria and its sequel. And also it dramatically improves the symptoms, improving the quality of life and also eliminating complications related with paroxysmal nocturnal hemoglobinuria. Note that eculizumab does not alter the underlying defect of the disease. However, the treatment needs to be continued on lifelong or until spontaneous remission of PNH happens, which happens in some minority of the patients. So, eculizumab is mainly to alleviate the signs and symptoms rather than as a cure for the disorder. Remember that point. Second thing is anti-thymocyte globulin, which has been used in the treatment of aplastic anemia with considerable success in paroxysmal nocturnal hemoglobinuria. Bone marrow transplantation effectively treats bone marrow hypoplasia, which is a serious cause of morbidity and mortality in paroxysmal nocturnal hemoglobinuria. And then hematopoietic stem cell transplantation using allogenic donors is the only curative therapy for paroxysmal nocturnal hemoglobinuria. So these are some of the treatment approaches towards PNH. Use of eculizumab, it improves the quality of life by alleviating the signs and symptoms. Anti-thymocyte globulin will take care of aplastic anemia, which is part of the presentation of paroxysmal nocturnal hemoglobinuria because of bone marrow involvement. And hematopoietic stem cell transplantation using allogenic donors is the cure for PNH. Coming to our next topic, it is advanced glycation end products. As you know from the wording, glycation means it's a non-enzymatic process. So non-enzymatic attachment of glucose to amino groups of proteins and also nucleic acids and lipids is the glycation, which makes advanced glycation and products. So glucose makes a Schiff base with amino group of proteins, which then forms cysteamine due to amidori rearrangement, and further reaction will yield advanced glycation and products. So as it is shown here in the figure, amino terminal of a protein attached with the glucose in a non-enzymatic process, and that depends on the concentration of the glucose in the blood. So because higher the concentration of glucose, higher the non-enzymatic attachment of glucose to amino groups, so making a Schiff base formation, and this Schiff base is rearranged to make amino ketone, that is eventually modified into further reactions will yield advanced glycation and products. Now, so hyperglycemia will increase formation of advanced glycation and products, and that will lead to like glycated proteins in the extracellular matrix and plasma, and that causes increase in cross-linking of collagen and binding of proteins to basement membrane of capillaries and increasing the thickness there. And also this increase in cross-linking of collagen will trap proteins like LDL, damage basement membrane like glomeruli, leading to nephropathy. Then attachment of AGEs on the receptor cells, activation of NF-kappa B, and that increases cytokines, procoagulant activity increased, endothelial dysfunction increased, leading to contributing to several complications of hyperglycemia that are seen in especially uncontrolled diabetes mellitus like retinopathy, neuropathy, nephropathy, and including cataracts. So this kind of things may go on whenever there is excess advanced glycation and products. So in poorly controlled diabetes mellitus, AGE formation is directly proportional to the concentration of blood glucose. So glycation of proteins, extracellular matrix proteins including collagen can alter their properties like collagen cross-linking process. AGEs can lead to increased attachment and internalization of LDLs by the endothelium, and thus it can contribute to atherosclerosis. And AGEs appears to be involved in both microvascular and macrovascular complications seen in diabetes mellitus, and non-enzymatic glycation of hemoglobin, that is measured as HbA1c, is proportional to the blood glucose concentration, and the percentage of HbA1c will determine or it will indicate the blood glucose levels for 16 weeks duration. So that's all about mucolipidoses, GPI anchors, paroxysmal nocturnal hemoglobinuria, advanced glycation and products. Thank you.